Welcome to the Department of Anesthesia, National University Hospital and Yong Lu Lin School of Medicine, NUS. Perioperative Echocardiography Training Program. Module 1. This module will take you through the recommended TEE views for non-cardiac surgery. There are 16 views to learn, obtained from the mid-esophageal, transgastric, and deep transgastric planes. The first view normally encountered is either the mid-esophageal 5-chamber or 4-chamber view. This is normally obtained at a depth of 40 centimeters. Here we have the ME5 chamber view. We can see all 4 cardiac chambers in addition to the LVOT. The multiplane angle is between 0 and 15 degrees for this view. The LV lateral and septal walls are seen, as well as the anterior and posterior mitral valve leaflets. This view allows us to make a quick global assessment of the heart and is a useful view to start with. Slight advancement of the TEE probe with the multiplane angle maintained between 0 and 15 degrees brings us to the mid-esophageal 4-chamber view. All 4 cardiac chambers are seen. An assessment of chamber size, global LV and RV function can be made. This view also allows for assessment of the tricuspid and mitral valve. The A3 and P1 scallops of the mitral valve are imaged here. The septal and lateral LV walls are seen here, just like in the ME5C view. We next obtain the ME Midcommissure view by keeping the probe at the same level as before, and rotating the multiplane angle to 60 degrees. The LA and LV is seen, together with the anterolateral and posteromedial papillary muscles. This view is one of the views used for assessment of the mitral valve, along with the ME4 and 5-chamber views. You can see P3, A2, and P1 scallops of the mitral valve, from right to left in this view. The multiplane angle is next rotated to 90 degrees to obtain the mid-esophageal 2-chamber view. The LA and LV is visualized. The basal, mid and apical segments of the anterior and inferior LV walls are clearly seen. The left atrial appendage can be visualized here as well. This view is useful for mitral valve assessment, with the P3, A2, and A1 segments seen. Color Doppler can be used to detect mitral regurgitation. We will next go on to obtain the mid-esophageal long axis view. The multiplane angle is rotated to between 120 and 140 degrees to obtain this view. Structures seen are the LA, LV, mitral valve, LVOT, and aortic valve. The P2 and A2 segments of the mitral valve are seen. This view is also used to measure the mitral valve annulus, anterior leaflet, and posterior leaflet length. Pulse wave Doppler can be used for assessment of mitral inflow velocities and to calculate the pressure gradient across the mitral valve. The basal, mid and apical segments of the infralateral LV wall are seen. The apical lateral, apical cap, and apical anterior segments are visualized, as well as the basal and mid anteroseptal segments. This allows for assessment of regional wall motion abnormalities in these segments. From this view, slight withdrawal of the probe brings the aortic valve into the center of the field. The multiplane is kept at between 120 and 140 degrees. This is the mid-esophageal aortic valve long axis view. The LVOT, aortic root, and proximal ascending aorta are clearly visualized here. Measurements of LVOT diameter, aortic valve annulus, sinotubular junction diameter, and proximal ascending aorta diameter can be made here in mid-systole. Withdrawing the probe from the ME-lax view allows imaging of the long axis of the ascending aorta. The right pulmonary artery is adjacent to the esophagus and posterior to the ascending aorta. Proximal pulmonary emboli may be visualized here. The diameter of the mid-ascending aorta can be measured in this view. Here, we can also assess the aorta for evidence of type A dissection. The short axis view is obtained by rotating the multiplane to between 10 and 20 degrees. The main PA and right PA are seen. The SVC can also be visualized here. We now return to the mid-esophageal aortic valve long axis, a view we previously obtained. From the previous view, this is obtained by advancing the probe slightly and rotating the multiplane to between 120 and 140 degrees. This then allows us to easily obtain the mid-esophageal aortic valve short axis view by rotating the multiplane to between 45 and 60 degrees. The aortic valve in short axis, resembling a Mercedes-Benz logo, is seen here. The depth is reduced to center the aortic valve, or the zoom function can be used to focus on the aortic valve. The non-coronary, right coronary, and left coronary cusps are labeled. This view allows for assessment of aortic valve pathology with use of color Doppler and 3D imaging. The mid-esophageal RV inflow-outflow view is obtained next. The multiplane is rotated to between 50 and 70 degrees. Slight advancement of the probe from the MEAVSAX view may be required. Right heart function, RV size and diameter, and RVOT diameter can be assessed. The tricuspid and pulmonic valve can be evaluated for valvular pathology and interrogated with spectral and color Doppler. We next return to the mid-esophageal four-chamber view. The next view to be obtained is the bicable view. In order to obtain this, we must first center the right atrium in the screen by rightwards rotation of the probe. The multiplane angle is then rotated by 90 degrees to obtain the bicable view. Imaged in this view are the LA, interatrial septum, RA, IVC, SVC, and right atrial appendage. The interatrial septum is assessed for interatrial shunts. SVC and IVC inflow can be assessed here as well. This view is an important view during minimally invasive cardiac surgery. The surgeons will cannulate the femoral vein for venous drainage, and this is done by a Seldinger technique. With this view, we are able to see the guide wire and confirm its position in the RA, as well as confirm the final position of the venous cannula. We next obtain the modified bicable view by rotating the multiplane angle to between 110 and 120 degrees. The tricuspid valve comes into view and should be assessed with color Doppler and spectral Doppler. We next obtain the transgastric views. The TEE probe is advanced into the stomach and antiflexed. The TG basal sacs view can be recognized by the fish mouth appearance of the mitral valve. The posterior mitral valve leaflet is on the left, whilst the anterior leaflet on the right. The basal LV segments of the inferior, lateral, septal, and anterior LV walls are seen and can be assessed for RWMA. Color Doppler can be used to interrogate the mitral valve. Advancement of the T probe allows visualization of the mid-papillary transgastric view. This view provides significant diagnostic information and can be extremely helpful in assessing LV size and volume status, and global and regional function. This is the primary TG view for intraoperative monitoring of LV size and function, because myocardium supplied by the left anterior descending, circumflex, and right coronary arteries can be seen simultaneously. Turning the probe to the right from this view will typically image the mid-RV in SAX. Rotation of the multiplane to 90 degrees reveals the TG2 chamber view with the inferior LV wall at the top of the screen and the anterior wall at the bottom. The mitral valve, cords, and papillary muscles can be seen, as well as the left atrium and left ventricular cavity. The left atrial appendage can be seen here as well. Rotation of the multiplane to 120 degrees brings us to the TG lax view, where the aortic valve is seen and is in alignment for Doppler interrogation. The deep transgastric 5C view is obtained next. The multiplane is returned to 0 degrees and advanced to the apex of the heart. The probe is then antiflexed. The heart is imaged from the apex with visualization of all four chambers and the LVOT. This view is useful for color and spectral Doppler interrogation of the LVOT and aortic valve. The descending aorta is finally imaged by turning the probe to face posteriorly. It is imaged in the short axis with multiplane at 0 degrees and in the long axis with multiplane at 90 degrees. The descending aorta can be followed proximally to reach the aortic arch by withdrawing the TEE probe. Here is a summary of the TEE views we have gone through today. The mid-esophageal views allow assessment of the LV and RV. Additionally, the ME4C, midcommissural, ME2C and ME long axis are used in combination for assessment of the mitral valve. The TG views allow for dynamic assessment of the LV. The aortic valve is assessed with a combination of ME and TG views. This video serves as a roadmap for obtaining the TEE views in a stepwise manner. The HeartWorks Echo Simulator is available in the department for practice of these views. Hands-on experience can be obtained in the cardiac operating room, either during your cardiac posting or as part of a TEE training program. Please read the accompanying additional reading material available with this module. The online MCQ exam should be completed before starting the next module. Thank you.